To address the clinical issue of assessment and monitoring, our key clinical activities are to assess asthma severity, initiate therapy, to assess asthma control, and to monitor and adjust therapy, and to schedule follow-up care. Our action steps related to these activities are to use severity classification chart assessing both domains of impairment and risk to determine initial treatment, to use the asthma control chart assessing both domains of impairment and risk to determine if therapy should be maintained or adjusted, to use multiple measures of impairment and risk, different measures to assess different manifestations of asthma. They may not correlate with each other and they may respond differently to therapy. You also want to obtain lung function measures by spirometry at least every 1 to 2 years, more frequently for not well-controlled asthma. Asthma is highly variable over time and periodic monitoring is essential. In general, consider scheduling patients 2 to 6 week intervals while gaining control, at 1 to 6 month intervals depending on step of care required or duration of control to monitor if sufficient control is maintained, or at 3-month intervals if a step down in therapy is anticipated. To assess asthma control, medication technique, written asthma action plan, patient adherence, and concerns at every visit. To address the clinical issue of education, our key clinical activities are to provide self-management education, developing a written asthma action plan in partnership with the patient, and to integrate education into all points of care where health professionals interact with patients. Our action steps related to these activities are to teach and reinforce self-monitoring to assess level of asthma control and signs of worsening asthma. Either symptom or peak flow monitoring shows similar benefits for most patients. Peak flow monitoring may be particularly helpful for patients who have difficulty perceiving symptoms, who have a history of severe exacerbations or moderate to severe asthma. This is a peak flow meter. You can see the numbers here. The green indicates your best, and then yellow is worse, and red is severe impairment. You use it by moving this indicator to the bottom. You put your thumb like this. You take a deep breath in, and then you blow fast and hard. It'll blow this indicator to whatever number, and then you can see how bad your symptoms actually are and what needs to be done about it. You can use a written asthma action plan. You want to make sure you take your medication correctly. You want to avoid environmental factors that worsen your asthma. You want to tailor education to the literacy level of the patient and appreciate the potential role of the patient's cultural beliefs and practices in asthma management. You want to make sure that you agree on treatment goals and address patient concerns. You want to provide instructions for daily management and for managing worsening asthma. You want to involve all members of the healthcare team in providing or reinforcing education, including physicians, nurses, pharmacists, respiratory therapists, and asthma educators. You want to encourage education at all points of care in the clinics, in the ER, in the hospital, in pharmacies, in schools, and in other community settings, even the home. You want to use a variety of educational strategies and methods also. To address the clinical issue of controlling environmental factors and comorbid conditions, our key clinical activities are to recommend measures to control exposures to allergens and pollutants or irritants that make asthma worse, and to treat comorbid conditions. Our action steps related to these activities are to determine exposures, history of symptoms and presence of exposures and sensitivities. You want to advise patients on ways to reduce exposure to those allergies and pollutants or irritants to which the patient is sensitive. Multifaceted approaches are beneficial. Single steps alone are generally ineffective. Advise patients and pregnant women to avoid exposure to tobacco smoke. Consider allergen immunotherapy by specifically trained personnel for patients who have persistent asthma and when there is clear evidence of a relationship between symptoms and exposure to an allergen to which the patient is sensitive. Consider especially allergic bronchopulmonary aspergillosis, gastroesophageal reflux, obesity, obstructive sleep apnea, rhinitis and sinusitis, and stress or depression. Recognition and treatment of these conditions may improve asthma control. Consider inactivated influenza vaccine for all patients over 6 months of age. To address the clinical issue of medications, our key clinical activity is to select medication and delivery devices to meet the patient's needs and circumstances. Our action steps related to this activity are to use the stepwise approach, which we will discuss later, to identify appropriate treatment options. Inhaled corticosteroids are the most effective long-term control therapy. When choosing among treatment options, consider domain of relevance to the patient's history of response to the medication, and the patient's willingness and ability to use the medication. Now we will discuss the stepwise approach. The goal of the stepwise approach is to recommend treatments that are meant to assist, not replace, the clinical decision-making necessary to determine the most appropriate treatment to meet the individual patient's needs and circumstances. To address the clinical issue of general principles for all age groups, our key clinical activities are to incorporate 4 components of care, initiate therapy based on asthma severity, and adjust therapy based on asthma control. Our action steps related to these activities are to include medications, patient education, environmental control measures, and management of comorbidities at each step. You want to monitor asthma control regularly. For patients not taking long-term control therapy, select treatment step based on severity. Patients who have persistent asthma require daily long-term control medication. Once therapy is initiated, monitor the level of asthma control and adjust therapy accordingly. Step up if necessary and step down if possible to identify the minimum amount of medication required to maintain asthma control. Refer to an asthma specialist for consultation or co-management if there are difficulties achieving or maintaining control. Step 4, care or higher, is required. Immunotherapy or omalizumab is considered, or additional testing is indicated, or if the patient required 2 bursts of oral systemic corticosteroids in the past year or a hospitalization. For the age group of 0 to 4 years, the key clinical activities are to consider daily long-term control therapy, to monitor response closely and adjust treatment. Our action steps related to these activities say that young children may be at high risk for severe exacerbations, yet have low levels of impairment between exacerbations. You want to initiate daily long-term control therapy for children who had greater than or equal to 4 episodes of wheezing the past year that lasted more than a day and affected sleep, and who have a positive asthma risk profile. Either one of the following: a parental history of asthma, physician diagnosis of atopic dermatitis, or evidence of sensitization to aeroallergens, or 2 of the following: sensitization to foods greater than or equal to 4% blood eosinophilia, or wheezing apart from colds. Consider initiating daily long-term control therapy for children who consistently required short-acting beta agonist treatments more than 2 days a week for greater than 4 weeks. Children who have 2 exacerbations requiring oral systemic corticosteroids within 6 months. And if no clear and positive response occurs within 4 to 6 weeks and the patient's caregiver's medication technique and adherence are satisfactory, you want to stop the treatment and consider alternative therapies or diagnosis. If clear benefit is sustained for at least 3 months, consider a step down to evaluate the continued need for daily therapy. Children this age have high rates of spontaneous remission of symptoms. For the age group of 5 to 11 years, the key clinical activities are to involve the child in developing a written asthma action plan, to promote physical activity and monitor for disease progression and loss of lung growth. Our action steps related to these activities are to address child's concerns, preferences, and school schedule in selecting treatments, to encourage the students to take a copy of their written asthma action plan to school or after-school activities, to treat exercise-induced bronchospasm. You want to step up daily therapy if the child has poor endurance or symptoms during normal play activities. The treatment will not alter underlying progression of the disease, but a step up in therapy may be required to maintain asthma control. For children who are 12 and older, the key clinical activities are to involve youth in developing written asthma action plan, to promote physical activity, to assess the possible benefit of treatment in older patients, and adjust medications to address coexisting medical conditions common among older patients. Our action steps related to these activities are to address the youth's concern, preferences, and school schedule in selecting treatment, to encourage the students to take a copy of their written asthma action plan to school or after-school activities, to treat exercise-induced bronchospasm, to step up daily therapy if the child has poor endurance or symptoms during normal daily activities, to establish reversibility with a short course of oral systemic corticosteroids. Consider, for example, calcium and vitamin D supplements for patients who take ICS and have risk factors for osteoporosis. Increased sensitivity to side effects of bronchodilators with increasing age. Increased drug interactions with theophylline. Medications for arthritis, hypertension, or glaucoma may exacerbate asthma. To address the clinical issue of exercise-induced bronchospasm, our key clinical activity is simply to prevent exercise-induced bronchospasm. Our action steps related to this activity give some treatment strategies to prevent EIB, like long-term control therapy, pre-treatment before exercise with a short-acting bronchodilator, leukotriene receptor antagonists, cromolyn or nedocromil, frequent or chronic use of long-acting beta-2 agonists for pre-treatment is discouraged as it may disguise poorly controlled persistent asthma in a warm-up period or a mask or scarf over the mouth for cold-induced EIB. To address the clinical issue of pregnancy, our key clinical activity is to maintain asthma control throughout the pregnancy. Our action steps related to this activity are to monitor asthma control during all prenatal visits. Asthma worsens in 1/3 of women during pregnancy and improves in 1/3. Medications should be adjusted accordingly. It is safer to be treated with asthma medications than to have poorly controlled asthma. Maintaining lung function is important to ensure oxygen supply to the fetus. Albuterol is the preferred short-acting bronchodilator. ICS is the preferred long-term control medication. Budesonide is preferred because more data is available on this medication during pregnancy. To address the clinical issue of surgery, our key clinical activity is to reduce the risk of complications during and after surgery. Our action steps related to this activity are to assess asthma control prior to the surgery. If the lung function is not well controlled, you want to provide medications to improve their lung function. A short course of oral systemic corticosteroids may be necessary. For patients receiving oral systemic corticosteroids during 6 months prior to their surgery, and for selected patients on high-dose ICS, you want to give 100 milligrams hydrocortisone every 8 hours through their IV during the surgical period, and reduce the dose rapidly within 24 hours after the surgery.